Okay, good morning, everybody. Welcome back to part number 2 for chapter 15, respiratory emergencies. Okay, so we first talked about croup, and we talked about stridor, how croup is an inflammation and swelling of the upper airway of the pharynx, larynx, and the trachea, and how when somebody coughs, they have a seal-like bark. That's called stridor. And croup is very rarely seen in adults because their breathing passages are larger and we can accommodate the swelling. Croup is very common with younger children, and the stridor is very common with younger children when they have a really, really bad cough. And then you hear that seal-like bark. We talked about epiglottitis, which is a swelling of the epiglottis, which is the leaf-like structure that covers the airway, the trachea. It covers the trachea and the larynx during swallowing. It's a bacterial infection. It's very common to see in kids, and the epiglottis can actually swell at 2 to 3 times its normal size. And by that occurring, it puts the airway at very, very high risk of obstruction. And an obstructed airway means that somebody can't breathe. So then they go into respiratory arrest. They go from respiratory distress to respiratory arrest, and then it puts you into cardiac arrest. So you want to get that taken care of as quickly as possible. Treat children with suspected epiglottitis gently and try not to do anything that will cause them to cry. Keep the person in a position of comfort. Give them high flow O2, which in this case would be a non-rebreather, 15 liters per minute, and the saturation level is at 80 to 90% saturation. And you don't want to put anything in their mouth. Nothing goes in their mouth. Okay? So you also have another thing that's called RSV. That's respiratory syncytial virus. It is it is a common cause of illnesses in young children. It causes an infection in the lungs and breathing passages, which can lead to other serious illnesses such as bronchiolitis and pneumonia, as well as serious heart and lung problems in premature infants and in children who have depressed immune syndrome. RSV is highly contagious, and it can be spread through droplets when the patient coughs or sneezes. The virus can also survive on surfaces including hands and clothing. Therefore, the infection tends to spread rapidly through schools and child care centers. When you assess or when you review or examine a child with suspected RSV, look for signs of dehydration. Infants with RSV often refuse liquids. Treat airway and breathing problems as appropriate. Humidified oxygen is extremely helpful. When you are in the back of the ambulance and you want to give somebody humidified oxygen, you have the O2 port that's coming out of the wall. There's a container you can actually put sterile water in, and you connect it to that. It's like a cup with a lid on it. And the oxygen goes into that, creates bubbles, and then the humidified oxygen goes to the top, and then it comes out the O2 tubing, and it goes to the patient's device that you have in the face, whether it's a nasal cannula or it's a non-rebreather. In this case, it would be a non-rebreather because you want to give as much oxygen as possible. You have another one that's called bronchitis. Bronchitis is a respiratory illness that often occurs due to respiratory that is caused by RSV. It's a severe inflammation of the bronchioles. The bronchioles are tiny airways that lead from the larger airways, the bronchi, to the alveoli in the lungs, which become inflamed, swell, and fill the lungs. So the best way for me to describe this, you guys understand what the main bronchi and the bronchioles and the alveoli are, is picture a tree during the summertime or during the fall, and it's full of leaves. You've got the main trunk of the tree that goes up, and then you've got the big branches that come out. Okay? Then from the big branches, you have smaller branches, and what's at the end of those smaller branches? All of the leaves. So consider the main trunk of the tree, the airway in your mouth. It comes down your mouth into your lungs. Okay? That's your airway. That's the main trunk of the tree. But take the tree and put it upside down. So the leaves are up here, the trunk's down here. Flip it around. So the leaves are down here, and the airway's here. So you got the airway that comes down, which is the trunk of the tree. Okay? Then you have the main branches, okay, which are called the main bronchi. the airway splits. Some of the branches go into the right lung, some of the branches go into the left lung. Those are called your main bronchi, the main branches. Then you have the smaller branches, which are called the bronchioles. And those are the smaller branches that branch off of the main bronchi, into all areas of the lung. And at the end of those bronchioles, or the small branches, are the leaves. But instead of the leaves, you've got the alveoli, the millions and millions of bunches of grapes. So the air comes in, goes in your airway, main bronchi, bronchioles, alveoli. Gas exchange takes place, oxygen goes into your blood, waste, CO, comes back into your lungs, and you breathe it out. I hope I was able to explain that in a way that makes sense for you. Then you have pneumonia. Pneumonia is a general term that refers to an infection of the lungs. The infection collects in the surrounding normal lung tissue, impairing the lung's ability to exchange oxygen and carbon dioxide. Pneumonia is often a secondary infection, meaning it begins after an upper airway tract infection, such as a cold or sore throat. So pneumonia normally starts up here, and then it slowly goes down to here. And what it does, in your body's attempt to protect itself, it creates a lot of extra mucus. Well, and unfortunately, in doing so, that mucus builds up, and gravity is your worst friend in this case, because then the mucus and the fluids build up, and they start to fill your lungs up. And as I said earlier, you say your lung goes from here. Actually, your lung goes from about here down to way about here, okay, in the front. And then in the back, it goes even lower. It goes down to almost to your waist there, almost to your waist. But when you have pneumonia, it's very possible that this much of your lungs are completely submerged in this mucus and liquid. So instead of having the area from here to here to breathe, you're only able to breathe from there to here, because this portion is all full of gunk and crap. That's pneumonia. And the best way to get rid of pneumonia is they put you on antibiotics and medicines to help get that stuff out. Okay? There's another infection out there that's called pertussis, otherwise known as the old whooping cough. And basically what that is a patient with pertussis will be feverish and exhibit a whoop sound on inspiration after a cough attack. Symptoms are generally similar to colds, but coughing spells can last for more than a minute, during which the child may turn red or purple. This may frighten the parents or caregivers into calling 911. Okay? Whooping cough is an airborne bacterial infection that primarily affects children younger than 6 years of age. It is highly contagious and is passed through droplet infection. Droplet infection, just like the bronchitis. Okay? Just like croup. So as you can see, a lot of these respiratory illnesses are caused by infection when somebody coughs and the droplets go out, and you're walking by somebody, they cough, and you walk right through their cough. You just inhaled some of their droplets. And if they're sick, guess what? You have a 50-50 chance of getting sick. Probably 75-25, depending on how well your immune system is. Okay? So those are some of the infections that can happen. You have influenza type A. Influenza is an animal respiratory disease that has mutated into humans. Remember in 2009 when you had the H1N1? Guess what? That was influenza. That was the flu. Okay? But it was a stronger strain of the flu. Then you have tuberculosis, otherwise known as TB. TB is a bacterial infection caused by Mycobacterium tuberculosis. TB spreads by cough and is dangerous because many strains are resistant to antibiotics. TB is not as prevalent as it was 30, 40, 50 years ago, but it's still out there and people can still get it. We have a lot of ways to treat it, but it is still a very strong strain of that tuberculosis strain, and it says here that it's a lot of strains are resistant to antibiotics. Somebody who has TB, you need to put a mask on them and a mask on yourself right away. Sometimes it's difficult to find out if the person has TB unless you read it in their chart, or they tell you, yeah, I have TB. As soon as you find out they have TB, get that mask on them and you right away. Okay? Now you have something that's called pulmonary edema. Okay? So I'm going to read this section out to you real quick. Acute pulmonary edema. Sometimes the heart muscle is so injured after a heart attack or some other type of injury from illness or trauma that it cannot circulate blood properly. In these cases, the left side of the heart cannot remove blood from the lungs as fast and as efficiently as the right side delivers it to it. As a result, fluid will build up within the alveoli in the lung tissue between the alveoli and the pulmonary capillaries. This accumulation of fluid is referred to as pulmonary edema, and it is usually a result of congestive heart failure. So basically, the best way for me to describe this is, let's talk about the blood flow through the heart. When blood comes back to the heart, it's either deoxygenated or it's oxygenated. Blood from the body returns on both sides of the heart. When blood returns to the heart, it always returns to the top of the heart. On the right side of your body, it comes back to the superior and inferior vena cava, comes to the upper right atrium, goes down to the bottom right ventricle, goes out to the lungs to get oxygenated. It dumps off all the CO and the waste that it has, and it picks up as much oxygen as it can handle. It comes back to the heart. It comes back to the heart on the top left atria, goes down to the bottom left ventricle, and then from there, it's pumped out to the rest of the body through the aorta as highly oxygenated bright red blood. Okay, if for some reason the left side of the heart is it's injured, as it said in the book, and it's not as effective as pumping all that blood out as fast as the right side gives it, it's going to have a buildup of fluid in the lungs. Because remember, it goes right side, upper right, lower right, out to the lungs, dumps off all the waste, picks up all the oxygen, comes back to the heart. Okay? The left of the heart, it's weak. It can't pump it out that fast because it's injured or it's sick. Something's wrong with it. So it's at 75% capacity. Well, this is at 100% capacity. So the difference between 100% and 75% is 25%. So where's that 25% extra blood going? It's sitting here in the lungs because it just can't get pumped out fast enough. There's a backup of fluids, and that's pulmonary edema. Okay? COPD, chronic obstructive pulmonary disease, is a slow process of dilation and disruption of the airways and of alveoli caused by chronic bronchial obstruction. Okay? COPD may be a result of direct lung and airway damage from repeated infections or inhalation of toxic gases and particulates, most often related to smoking and vaping. So those of you who smoke or vape, please stop. It's going to kill you. It's going to mess up your lungs. Okay? Although it is well known that cigarettes and vaping are a direct cause of lung cancer, their role in the development of COPD is far more significant and very less publicized. Okay? So keep that in mind. Tobacco smoke is a bronchial irritant and can create chronic bronchitis. With bronchitis, excessive mucus is constantly produced, obstructing small airways and the alveoli. Protective cells and lung mechanisms that remove foreign particulates are destroyed and are further weakening the airways. So the lung mechanism, the protective cells and lung mechanisms that remove the foreign particles are destroyed and they can't do their job. So all those foreign particles that are poisonous, that are bad for your lungs, guess what? They just sit there because the part of the body that's supposed to get rid of them, they can't do it, or they can't do it as effectively. So please don't smoke and vape. Do not vape. The most common form of COPD, chronic obstructive pulmonary disease, is called emphysema. Emphysema is a loss of the elastic material in the lungs which occurs when the alveoli air spaces are chronically stretched due to inflamed airways. So basically what that means is that when we breathe, when I told you, when you ventilate, ventilation is moving air in and out of the lungs. Okay? Respiration is the exchange of gases, is the process of exchanging, is what we call when O2 and CO are exchanged in the lungs. Okay? But in that process, you have a process called, you got a definition, you got a sub-definition of a definition. that subdefinition of respiration is called diffusion. And diffusion is when molecules of a higher concentration move into an area of lesser concentration. In this case, the lungs have a high concentration of oxygen, the blood has high concentration of CO, and they exchange at the alveoli in the capillaries. Okay? What happens is that when we breathe, as I said, the lung, the chest, the diaphragm goes down, creating negative pressure in the chest cavity. Our chest cavity expands, our lung expands, and we breathe as much air as we possibly can. With emphysema, when our lung expands, the alveoli expand. The grape is like a balloon. It gets bigger. It gets bigger so it can maximize the amount of oxygen that it sends out and CO that accepts. But that alveoli, or the alveoli, the grape, loses its elasticity. It just stays in one size. It doesn't get bigger, it doesn't get smaller, it just stays one size. So it loses its elasticity. So that hinders your ability to complete air exchange in your lungs. So you have a higher level of CO, can't get that good of exchange of gases within your lungs, and you have respiratory issues, hence emphysema. Okay? Let's see. You have asthma, hay fever, otherwise known as anaphylaxis. Okay? Asthma, hay fever, and anaphylaxis are the result of an allergic reaction to an inhaled, ingested, or injected substance. The substance itself, the item that's making you have this reaction, is called an allergen. Okay? The substance itself, allergen, is not the cause of the allergic reaction. Rather, it is an exaggerated response of the body's immune system to that substance that causes it. In some cases, however, there is no identifiable allergen that triggers the body's immune system. Sometimes they can't figure out what's going on. Okay? Your body's reaction to that unknown allergen. Your body is reacting to the allergen. So your body is overreacting to an unknown allergen, and it thinks it's protecting you. But a lot of times when it thinks it's protecting you, it's actually causing more injury and harm than good. It's your body's overreaction. It's your body's immune system as an exaggerated response or an overreaction to that substance. Okay? So your body is injuring you, not the allergen. Your body doesn't know what this is, so it's like, oh, it's an enemy, we're going to protect the body, we're going to do this, and in doing that, it takes your airway and it constricts it, makes the airway nice from big to small, and it takes your blood vessels, say, hey, we need more blood circulation, so it dilates your blood vessels, and it makes the garden hose of your arteries and veins, makes it bigger, so you can process more blood. But in the process, by restricting your airway, it's making it difficult for you to breathe. So what we do is we give you epinephrine or an EpiPen, and that medicine actually takes the muscles of your airway and it doesn't constrict them, it makes them relax. You know, someone who's having an anaphylactic shock, they're help me, I can't breathe. Okay, whether it's from a bee sting, a peanut, seafood, something that they're allergic to. When you give them epinephrine, it takes a couple seconds for it to take effect. But when you do, then it takes the airway and it opens up, and they go, oh, I can breathe now. Okay, but for every action, there's an equal and opposite reaction, and I believe that's Newton's third law. For every action, there's an equal and opposite reaction. So when your airway constricts because it's had an anaphylactic shock, it constricts, it gets smaller, so something's going to get bigger. That's going to be your arteries and your veins, and they get bigger. When we give you epinephrine, it takes the airway that's smaller and it allows it to relax, opens up your airway so you can breathe, but then it takes your arteries and your veins that were bigger and it constricts them. So when you give somebody epinephrine, a side effect is going to be increased blood pressure, increased pulse, which is good because it's still moving blood, and your airway's open, and you get all the oxygen that you need. Another respiratory emergency is asthma. Asthma is an acute spasm of the bronchioles associated with excessive mucus production and the swelling of the mucus lining in the respiratory system. So asthma is just basically a spasm of the bronchioles of the airway. And that's when a lot of people will end up taking an inhaler. Albuterol, Proventil, you take it, you inhale it, and it relaxes. relaxes your muscles. Okay? Let me see here. What else do we have here? Okay. Let's see here. Okay. So let's go through this. We're going to talk about the anaphylaxis reaction, which is on page 598. Okay, let's talk about spontaneous pneumothorax on page 599. A pneumothorax is a particular or complete accumulation of the air in the pleural space. A pneumothorax is often caused by trauma, but it can also be caused by some medical conditions as well. So, how can we do this? You can have it's a partial complete accumulation of air in the pleural space. So, pleural space. Take a look at page 599 and figure 510. You have your lungs, and then you have your chest cavity. Around each individual lung, you have a protective sac. And then the inside of your chest cavity, you have a lining that lines the inside of your chest wall. Okay? You have your lung, and you have the protective sac that protects the lung. There's a little space in between that. That's called the pleural space. And in that space, think of it like a submarine. A submarine has two holes, an inner hole and an outer hole. And in between those two holes, that's what they use to fill with air to make the submarine rise, and that's what they fill with water to make the submarine sink. Okay, so that's the pleural space in the human body, between the lung and the protective coating. In that space is a very slippery, viscous solution, okay, that helps the lungs get bigger and smaller when you breathe. And this makes it very easy for these two surfaces to rub against each other, sort of like oil. And by those two surfaces rubbing up against each other, it doesn't cause any irritation or friction, pain or discomfort because it's so slippery. Okay, what will happen is that air or blood will get in between that space, that pleural space. And with each respiration you do, some of that liquid or air is going to get in that space even more and is going to slowly increase. But there's only one thing that can move. It's like having a balloon within a balloon. In this space, this is balloon number one, this is balloon number two. As the air increases between these two balloons, balloon number one, which is your lungs, is going to start getting squeezed, and it's going to start collapsing it because the pressure in the bigger balloon is squeezing the smaller balloon. Okay, and in doing so, it collapses your lung. When it collapses your lung, that lung cannot breathe that much. Okay, so instead of having two lungs that are working, you have 1.5, or you might have one lung. So a pneumothorax is a particular or complete accumulation of air in the pleural space. Pneumothorax is the most often caused by trauma, but it can also be caused by some medical conditions. In these cases, the condition is called a spontaneous pneumothorax. It just happens very, very quickly. Okay, it can happen within 30 minutes, within 15 minutes. Normally, the vacuum pressure in the pleural space keeps the lung inflated. When the surface of the lung is disrupted, however, air escapes into the pleural cavity and results in a loss of negative vacuum pressure. The natural elasticity of the lung tissue causes the lung to collapse. The accumulation of air in the pleural space may be mild or severe. Spontaneous pneumothoraxes may occur in a patient with certain chronic lung infections or in young people born with weak areas of the lung. Patients with emphysema and asthma are at high risk for spontaneous pneumothoraxes when a weakened portion of the lung ruptures, often during severe coughing. Tall, thin men are also more susceptible than the rest of the population to development of spontaneous pneumothorax, particularly while performing strenuous activities such as heavy lifting. Okay. You have something, so when you start to have this, you're going to have severe chest pain. That's called pleuritic chest pain. It's a sharp stabbing pain on one side that the pain gets worse as you breathe. Okay? Now, they also have something that's called a pleural effusion. A pleural effusion is a collection of fluid outside of the lung on one or both sides of the chest. It compresses the lung or lungs and causes difficulty breathing. Obstructed airway. We all know about the obstructed airway. That's the old-fashioned way is called the Heimlich maneuver. Heimlich maneuver, you guys learned that when you took your CPR first aid course, so you know what to do with that. Let's see here. We talked about the pleural effusion. We talked about the obstructed airway, pleural effusion, spontaneous pneumothorax, pulmonary embolism. We talked about that, right? Okay, so basically when you get a blood clot and it goes to the heart, and you get a blood clot and you get one that goes to the brain, when you have a clot that goes to the brain, what happens? Wherever that clot decides to stop, from the clot and beyond, you have reduced or no blood flow at all. So that tissue starts to get mad and it starts to die off because there's no blood, there's no oxygen going to it. So in cases like that, that's when you're going to have a stroke, if you have a clot in your brain. If you get a clot in your heart, that's when you end up having a heart attack. When you have a clot that's in your, or an embolism that's in your lungs, that's called a pulmonary embolism. A blood clot that circulates through the venous system. Circulation cut off partially or completely. It significantly decreases blood flow, just like a blockage in the heart or the brain. And if it's large enough, it can cause sudden death. Hyperventilation. Hyperventilation is overbreathing to the point that arterial carbon dioxide falls below normal. It may be an indicator of a life-threatening illness. The body may be trying to compensate for high acidosis, which is the buildup of excessive acid in the body tissue. It can cause symptoms of a panic attack, anxiety, dizziness, numbness, and tingling or painful spasms in the hands or feet. Environmental exposure. Pesticides, cleaning solutions, chemicals, chlorine, and other gases can be released. Carbon monoxide is an odorless, highly poisonous, and produced by fuel-burning appliances and smoke. So carbon monoxide is what happens when you have a heater that goes down, and say your heater is not venting to the outside sufficiently enough, so it has a poisonous gas come into the house. You can't smell it, you can't taste it, so you don't know what's going on. It's produced from fossil fuel burning. Do not put yourself at risk. That's why you have to have CO detectors in your house. So you're going to do scene size up. So in this case, you're going to do your patient assessment. First thing is scene size up. Second category is primary assessment. Then you're going to do your history taking. Then you're going to do your secondary assessment. And then you're going to take your vitals. And then you're going to make a transport. And then you're going to make your second transport decision. You're going to do reassessment. Okay, so let's do scene size up. Scene size up. Make sure the scene is safe. Make sure you have your personal protective equipment, your PPE, your BSI on. Use standard precautions. Consider the possibility of infectious diseases or toxic substances are in the area. Be on the lookout. Make sure that you record everything you see, hear, and smell when you show up on scene, because you may have a very small portion of the story as to what's going on. Person difficulty breathing. Well, why are they having difficulty breathing? Are they having difficulty breathing because they've had pneumonia for the past 2 weeks? They have a history of asthma. They have a history of emphysema. Could be that there's poisonous gases in the house. You don't know. You don't know until you actually show up and you start to get the real story. So consider the MOI or the NOI. Okay, remember the scene size up is your first step. Okay, it's scene safety, BSI, number of patients, MOI or NOI, consider additional resources, consider C-spine stabilization. Those 5 steps make up your scene size up. Okay? So, mechanism of injury, MOI or NOI. Mechanism of injury is a trauma. Nature of illness is the NOI. Ask why 911 was activated. Okay? But you're going to be doing that during your primary assessment. Question the family and question the family or any bystanders to determine the nature of illness or mechanisms of injury. What happened? What's going on? The patient might have a hard time talking to you, so while your partner's getting oxygen ready, the wife could be telling you, well, my husband has a history of COPD. He has asthma. And we don't have that money, so we couldn't afford to buy his asthma medication. We ran out of 3 days ago. Because we're both retired and all we have is Social Security. And the medication is $120 for a month's supply. And they don't have $120. Okay? Primary assessment. Immediately identify life threats. Form your general impression. Note the age and position of the patient. Use ASP scale and ask the patient about chief complaint. So your first 5 steps: scene safety BSI, number of patients, MOI or NOI, consider additional resources, and consider C-spine stabilization. Bam, right there. Those first 5 steps are your scene size up. Now your next main category is your primary assessment. Primary assessment consists of verbalize your general impression of the patient, determine level of consciousness, LOC. Are they use ABPU and are they ALC times 4? ALC times 4, person, place, time, and event. Do they know who they are? Do they know their name? Do they know where they are? Are they at home? Are they in the grocery store? Time. Do they know what time of the day it is? And I'm not talking about 10 o'clock or 6 o'clock. Do they know it's morning, afternoon, or night? So it's person, place, time, and event. What's going on? Why did you call us here? Okay? How the patient presents to you, how the patient answers your questions will help determine if they have a respiratory issue. Remember we were talking back earlier in the chapter, someone who can only give you 1 or 2 words in between breaths? So if someone's trying to answer you and they're by themselves and they can only give you 1 or 2 words in an answer, that's going to stand out like a sore thumb. This person can't breathe. I need to help their breathing. Try to figure out what's going on. Okay? If they can't answer those 4 questions because they're becoming lightheaded, they have poor saturation, they have poor diffusion, they have poor perfusion, their oxygen saturation in their blood is very low, they're going to become lightheaded, they're going to become disoriented, they can't answer those questions accurately because they don't have enough oxygen in their body, so they don't know their name, they don't know where they are, they don't know what time of the day it is, or what day of the week it is, or what month it is, and they don't know why you called, or they don't know why they called, or they don't know why their wife or their husband or their caretaker called. They're confused. Okay? So they've got to be able to answer those questions to determine how aware their brain is. If they can't answer all of them, or they only answer a couple of them, make note of that. AVPU, is the patient alert or are they unresponsive? Okay? AVPU, A, are they alert? If they are they barely alert? Are they 100% alert like we are right now? U, are they unresponsive? Are they unresponsive completely no matter what you say or do to them? They don't respond, or they respond a little bit when you pinch their ear, pinch their shoulder, pinch the back of their arm. Okay? Do they respond to verbal or painful stimuli? Do they respond to you when you talk to them? Or they don't respond and you got to pinch their ear or their nose, not their nose, their ear or their shoulders with painful stimuli. Okay? Make notations of all that stuff. Okay? Then you're going to do ABCs, airway, breathing, circulation. Airway, are they breathing? Yes or no? If they are breathing, are they breathing between the 12 and 20 times a minute? Yes or no? If they're not, are they breathing too slow or are they breathing too fast? Okay, if you have to give them oxygen therapy, what type of device are you going to use? You're going to use a nasal cannula, a non-rebreather, or BVM. And what's the liter flow going to be of that oxygen? What's the saturation level going to be? Okay? I'm sorry, my dog wants to go outside. ABC, breathing, circulation. You're going to check their circulation. Where do you check the circulation at? You're going to check on their wrist. When you're checking their pulse on their wrist, what are you touching? You're touching their skin. So you can determine the skin color, temperature, condition. Is it cool and clammy? Okay? If it is cool and clammy, they could be going into shock, or they could already be in shock. Okay? When you take a pulse, What's the average pulse of a person? Okay, is their pulse too low or is the pulse too high? Okay, if it is too slow, why? If it's too fast, why? Okay, then you make a transport decision. Is this a scoop and screw or is this a stay and play? Is a person, they're a little bit, something's wrong, but it's not a life threat. Their life's not in danger right now. So I can take a few extra minutes and talk to them, trying to find out what's going on. Or it could be a situation, this person can barely breathe. I need to get them to the hospital as quickly as possible. Okay? At any time during the run, you can determine whether you want to call for advanced life support. You can call for cardiacs, paramedics can help you because there are interventions that they can do with that patient, for the patient, that we as basics cannot do. But it's up to us to determine whether we need help or not. And you can never go wrong when it comes to asking for help. Also, keep in mind that the primary assessment, which is your second step in a medical patient evaluation or for a trauma, in your 11 steps in the medical or trauma patient, the first 11 steps are exactly the same. The primary assessment, which is your second stage of things to do, is mainly designed to identify a life threat. And a life threat is bleeding or breathing. If someone can't breathe or they're not breathing, you fix it. If someone's bleeding, you fix it. But between the two, if you have both going on, you always handle the breathing first. The bleeding. You always handle the bleeding first. You can help somebody with their breathing, but if they're bleeding to death, 2 or 3 minutes, and spend 2 or 3 minutes trying to get their breathing going or assist them with their breathing, blood's still coming out of their body. They're losing fluid. They're going to be going into hypovolemic shock. Stop the bleed first. Stop it or slow it down. Once you get that taken care of, then handle the breathing aspect of it. Whether you give them oxygen, or you assist them with their breathing, or you breathe for them completely by giving them a BVM with an OPA in the mouth, or you call for ALS and they tube the patient. They put a tube down their throat and they breathe for them. Okay? Primary assessment. When you listen to the airways, you're going to check in a lot of places. You're going to check mid-clavicular, okay, right here on the clavicle bones, right where the nipples are. You're going to go right under the nipples. You can listen for lung sounds there. You can listen for mid-axillary, which is right in the armpit area. And then you're going to check in 6 areas in the back. Pretend this is my back. I'm going to check up here, in the middle, and down at the bases. And you don't go right side, right side, right side. You go right side, left side, right side, left side, right side, left side. Or you can go left, right, left, right, left, right. But you always want to check sides. Does the right side sound the same as the left side? You can start at the top and work your way down. Okay? As soon as you hear nice breath sounds, you're coming down a little bit. All of a sudden you start to hear gurgles, bubbling, Rice Krispies. That means that there's fluid or mucus in their lungs. Okay, you have to be able to identify how far up or how far down you hear this junk in their lungs. Okay, when you assess the circulation, assess the pulse rate, the rhythm, and the quality. Same thing with their breathing. If they're breathing, are they breathing adequately? Are they taking deep enough breaths? Are they taking rapid, shallow breaths? When you're checking for the pulse, is the pulse regular or is it sporadic? Is it skipping a beat? What's going on? And also count. Okay, you know what the pulse rate is for an average healthy adult. Is it within that range? If it's not, is it too fast or is it too slow? What could be causing it to go too slow, too fast? What do you do if it's going too slow and too fast? That's what this class teaches you. Transport decision. Address any life threats and proceed with transport. If you need assistance, if you need advanced life support, call for it. If you need extra manpower, call for it. Okay? That's why we're all on the clock. We're here to help each other. Okay? You want to investigate the chief complaint. You want to do your sample and your OPQRST. Sample, signs and symptoms, allergies, medications, past pertinent medical history, last oral intake, and events leading up to. I don't know if you guys have discussed this yet. I believe you should have. The signs and symptoms. A sign is something you see. Symptom is something the patient tells you. Allergies. Do you have any allergies? Do you have any allergies to medications? Do you have any allergies to the environment? Hay fever. Do you have any allergies to food products? Fish, bee stings, seafood, peanuts. Okay? Medications. Do you have any medications? Okay, a lot of people get medications from multiple different types of doctors. These doctors should be aware of all the medications that the patient is taking. If the patient gets a medication from Dr. A and they go to Dr. B and Dr. B prescribes the medication, but Dr. B doesn't know all the medications that Dr. A is giving them, they might give a medication that has a poor reaction with one of the medications that Dr. A is giving them. So the patient is starting this new medication, and all of a sudden he starts to have an adverse reaction because the medicines don't mix. The patient doesn't know this. Okay, doctors don't know because he goes to more than one doctor and he doesn't tell all the doctors the medication he's taking. So that's why you want to know medications. Past medical history. Is there anything in the past regarding your medical history that is connected with what's going on today? Well, if you got a 65-year-old guy giving you a call and he's complaining of chest pain and difficulty breathing and he has a history of a heart attack 5 years ago, guess what? The heart attack is relevant because it's pertinent to what's going on. When somebody has a heart attack, what happens? They have chest pain. They have difficulty breathing. PL, last oral intake. Why is that important? Well, I just had lunch 2 hours ago, and now I'm feeling sick and nauseous, and I'm vomiting all over the place. Well, it could be that you were allergic to something that you ate. It could be that you know that you were allergic to seafood, but you went to the restaurant, and the cook who had seafood on his hand prepared your Caesar salad and didn't wash his hands correctly enough. Okay, so there's a little bit of interaction, not good sanitary practice taking place in the kitchen. Okay? And events leading up to. What was going on before you called us? Sorry, my nose is so itchy today. What was going on? If you have a 35-year-old male who calls you to their house because he was having a difficulty breathing, he was getting lightheaded, and his wife was worried about him, but he has hay fever, and it's fall time, and he was out cutting the grass and raking leaves, guess what? His allergies kicked in really, really strong. Not a mild reaction to the allergies, but a massive reaction for whatever reason. Okay? Now all of a sudden, his allergies are kicking in. Okay? So that's why I want to know what was going on before. Say that 65-year-old man who was complaining of chest pain, difficulty breathing, had a heart attack 7 years ago. Well, he was outside shoveling snow, and the snow was about 3 inches thick, but it was heavy, wet snow. He just overexerted his heart. He just overexerted his cardiovascular system. So he's going to have chest pain, difficulty breathing. Okay? So you want to find out what were they doing. Could anything that they were doing before they called you be affecting or be a reason why they're calling you now? Okay? So that's sample. Signs and symptoms, allergies, medications, past medical history, last oral intake, and events leading up to. Now you have OPQRST. Onset, provocation, quality, radiation, severity, and time. Onset. Onset refers to, did it come on quickly or slowly? Did the pain or discomfort start last night, or did it just happen 3 minutes ago or 10 minutes ago out of the blue? That's why you called us. Okay? P for pain. On a scale of 0 to 10. OPQRST, onset, provocation. Onset. Did it come on quickly or slowly? Provocation. Does anything make it better or worse? I'm having chest pain. My shoulder hurts. Okay. Or my back really, really hurts. My chest hurts. Okay. Does it feel better when you sit up and straighten out? Yeah, it feels better. Okay. Or does anything make it worse? Yeah, when I breathe. Every time I take a breath, it hurts more. Okay. Q, quality. Can you describe the pain to me? Okay. Onset, provocation, quality, radiation, severity, and time. Quality, can you describe the pain for me? Is it sharp, stabbing, dull, crushing? Describe the discomfort to me. Describe the pain to me. Describe to me what's going on. Radiation, does the discomfort or pain go anywhere? Let's say for a heart attack, guys, substernal, center chest pain, left shoulder, possible jaw pain. Okay, females, chest pain here, pain in the jaw, sometimes in left shoulder, but also with females in the lower back. Females present with cardiac issues differently than men, and you need to understand that. Okay, so you can help identify what might be going on. Onset, probably quality, radiation, severity on a scale of 1 to 10. 1 being no pain, 10 being the worst pain you ever felt in your life. How would you rate the pain? Now you have a 17-year-old girl who's saying, let's say a 22-year-old guy. Say a 22-year-old guy complains of stomach pain. Okay, on a scale of 1 to 10, how would you rate it? Oh, it's a 9, man. Oh, it's really, really bad. Okay. Believe what the patient says. Sometimes patients tend to over-exaggerate the pain, but I'm not saying everybody does. But the example what I'm trying to say is, you have a person who's never experienced pain that much in their life, and they tell you what it is. They're probably accurate, okay? But let's say you have a female, a 32-year-old mom who's had 2 kids already. Okay, she's given birth to 2 kids. Being pregnant and giving birth is extremely painful. Okay, my wife's done it 3 times. When you have an adult female who's given birth, and you say, ma'am, on a scale of 1 to 10, how would you rate the pain? And she tells you it's a 9, believe her, because they've experienced pain through childbirth. So when they tell you it's a 9, you believe them. It's a 9. Okay, simple as that. OPQR severity and time. When did it happen? Quality refers to, onset refers to when it started. Okay, did it come on quickly or suddenly? T, time, when did it actually start? Started at 7 o'clock last night? Okay, great. So your pain started around 7 o'clock last night, and the onset was very slow, but it got worse over time. Okay, or time, it started 20 minutes ago, and the onset is it came on suddenly, acutely. Okay, so that does that. Let's see. So we have another one's called PASTE, P-A-S-T-E assessment. It's specific for patient with difficulty breathing. It's progression associated with chest pain, sputum, talking tiredness, and exercise tolerance. Okay, progression. Is it getting bad really fast, or is it progressing very slowly? Is there chest pain? How much chest pain? Describe the chest pain and what's the pain level. Sputum. Are they spitting up pink frothy out of their lungs? Talking tiredness. Do they seem really, really tired when they're trying to talk? They have to use a lot of energy to talk, to answer your questions. And exercise tolerance. Okay? Secondary assessment. Okay, so you've done your history. You've done your OPQRST. You've done your sample. Now you're going to go to your secondary assessment. This is a more in-depth. The secondary assessment is designed, you are going to evaluate the body part or the body system that the patient called you about. If they called you about chest pain and difficulty breathing, are you going to worry about the lower extremities? Are you going to check their toes out? No, it has nothing to do with what's going on up here. If the patient is complaining of dizziness, lightheadedness, you're going to concentrate up here and your lungs and your chest, because these are associated with what goes on up here. If the person's just worried about difficulty breathing, are you going to worry about their stomach? Not as much as I am their lungs to find out what's going on. Okay? There are a couple different areas of the human body that we're going to investigate when it comes to the chief complaint with a medical patient. Specifically, there's going to be 8 of them. Secondary assessment. We're going to evaluate the cardiovascular system. Okay? We're going to evaluate the cardiovascular is the heart. We're going to evaluate the pulmonary system, which is the lungs. Neurologic system. We're going to have the person do FAST, face, arm, speech, and time, when you check them for a possible stroke. Face, when they're talking to you, is one side lower than the other? When they stick your tongue out, does the tongue go to one side? When you have them smile, does one side of the face go like this, and another side of the face go up, like that? Okay? When you have them put their hands out, close their eyes and have them extend their hands out. Okay, you can have hands open or hand closed. Close your eyes, and ideally when you close your eyes, your hands are supposed to stay even. But someone with a suspected stroke, one of the arms, usually the left side, will list. It'll start to drift away. Okay? Then have them grip your hands and squeeze as hard as you can. Okay? Is one hand stronger than the other? Is one hand can barely squeeze, and the other hand's really, really strong? And then have them push up on your hands and have them push down. Are both hands just as strong, or is one hand stronger and one hand's weaker? Okay? You're going to check the musculoskeletal system. You're going to check the skin, which is the integumentary, the GI, or the reproductive system, and you're going to check for psychological issues as well. Okay? Those are the 8 sections. You need to know those. Cardiovascular, pulmonary, neurological, musculoskeletal, integumentary, GI, reproductive, and psych. Okay? After that, you're going to do your vital signs, blood pressure, pulse, respirations. Those are the 3 main ones you have to get. Okay? You walk into a hospital, the first thing they're going to say, what do you got? Did you get vitals? You better have an answer. If you don't have an answer, the nurse is going to look at you like you're crazy. You shouldn't be an EMT. Plus, you should. Okay, blood pressure, pulse, respirations. To that, you can also add the FAST, face, arm, speech, and time, which is the neural check. You can check the pupils, equal reactive. Okay, you can do a BGL, blood glucose level. Okay, and you want to do an SpO2, oxygen saturation in the blood, and you can do that by using the SpO2 monitor. Okay, you're going to state your field impression of the patient, and you're going to tell them what you did in the field, and at that point, you're going to reassess the patient. And for a stable patient, you're going to reassess them every 15 minutes. Non-stable patient every 15 minutes. Okay. Let me see here. What else do we got to do? You need to make sure you know how to put an OPA and an NPA in. An OPA, oral pharyngeal airway. How you measure it from the corner of the mouth to the earlobe. Put it in upside down until you meet resistance. Turn 180 degrees. Finish putting it in, and you can have it rest on the lips or the teeth. Okay. NPA, nasopharyngeal airway. You measure it from the tip of the nose to here. Okay. You determine the size. Well, that determines the diameter. And then when you're putting it into the human body, you lube it up with some water-soluble gel. On the right side, the bevel is facing the middle of the nose, and you slide it right in. On the left side, you're going to do it the opposite way. You're going to put it so the bevel's facing out the left shoulder. You're going to put it so the bevel's facing the middle of the body, just like you did on this one. You're going to push it into your beat resistance, which is about halfway. Then you're going to turn it 180, and you're going to finish putting it in. Why do you meet resistance going into the nose? It's got something to do with the nasal, with the bone structure in the nose area, in nasopharyngeal airway. So basically what you want to do is you want to keep in mind that when you are completely have the NPA inserted, the nasopharyngeal airway, whether it's the right nose or the left nose, that bevel cut, when it's fully inserted, should be facing the left shoulder. Okay? And let me see here. Is there anything else? We talked about the pneumothorax, the spontaneous pneumothorax. We talked briefly about the pleural effusion, the obstructed airway, pulmonary embolism, hyperventilation. Hyperventilation is just when a person breathes too much and they have too little CO in their body. You'll find that very popular with people who are divers. And then they jump in. They're hyperventilating themselves. They're trying to maximize the amount of oxygen that's in their blood. But sometimes they have a possibility of putting so much oxygen that they don't have enough CO in their body. And your body's supposed to have a certain level of CO in it as well. The body's a very complicated system. So many systems and organs all working independently and all working in together for the body to remain in homeostasis. Okay, for the body to be happy. Let's see. Sometimes people might have a trach or tracheotomy, which is the doctors actually cut a hole, slit in their throat, and they put a tube in there, and that's how they breathe. Sometimes people have difficulty with that. It'll become irritated. The air becomes swollen, and doing so reduces their airway. Give them humidified oxygen, high flow oxygen, put them in a position of transport, keep them warm, and get them to the hospital as quickly as possible. Okay? Certain people have cystic fibrosis, which is a genetic disorder that affects the lungs and the digestive system. Put them in a position of comfort, oxygen, and transfer to the hospital as quickly as you possibly can. And that does it for that. Now let's do a quick chapter review with some questions. Question number 1. The process in which oxygen and carbon dioxide are exchanged in the lungs is called what? A, respiration, B, ventilation, C, metabolism, or D, inhalation. What do you think the answer would be? The answer would be A, respiration. Let's see. Okay, number 2. Which of the following respiratory diseases causes obstruction of the lower airway? Which of the following respiratory diseases causes obstruction of the lower airway? Is it A, croup, B, asthma, C, epiglottitis, or D, laryngitis? Which of the following respiratory diseases causes obstruction of the lower airway? It would be B, asthma. Okay. Let's see here. Okay. Number 3. Which of the following diseases is potentially drug resistant and is thought to be transmitted by coughing? Which of the following diseases is potentially drug resistant and is thought to be transmitted by coughing? Hint, hint. Coughing. Okay. And is resistant to antibiotics, which is what they call it, drug resistant. Remember we talked about it? It's called TB. I was going to say question answer A, tuberculosis, B, croup, C, diphtheria, or D, epiglottitis. And the answer is A, tuberculosis. Did I miss it? Okay, number 4. Where are you? Okay, there we go. All of the following are causes of acute difficulty breathing except. All of the following are causes of acute dyspnea except A, asthma, B, emphysema, C, pneumothorax, or D, pulmonary embolism. All of the following are causes of acute dyspnea, difficulty breathing, except asthma, emphysema, pneumothorax, or a pulmonary embolism. The answer is B, emphysema. Emphysema takes time. Emphysema, which is a form of COPD, is a chronic respiratory disease. Therefore, it presents with progressively worsening difficulty breathing. Okay. Keep going backwards on this. Okay, number 5. A bronchospasm is most often associated with what? Asthma, bronchitis, pneumonia, or pneumothorax? Bronchospasm is most commonly associated with what? Asthma, bronchitis, pneumonia, or pneumothorax? Remember, a pneumothorax is a buildup of air and or fluid. Pneumonia is a filling up of the lungs. So that leaves either asthma or bronchitis. The answer would be asthma. Asthma is a reactive airway disease and is caused by bronchospasms. Common triggers to acute asthma attack include environmental allergens, stress, and temperature changes. Number 6. A sudden onset of difficulty breathing, sharp chest pain, and cyanosis. Remember cyanosis, discoloration around the lips and the nose, that persists despite supplemental oxygen is most consistent with a sudden onset of difficulty breathing, sharp chest pain, and cyanosis that still continues to occur no matter how much oxygen we give the patient is consistent with what? A, severe pneumonia, B, myocardial infarction, C, pulmonary embolism, or D, spontaneous pneumothorax. It would be C, a pulmonary embolism. Signs of an acute pulmonary embolism include a sudden onset of difficulty breathing, sharp chest pain, and cyanosis that persists despite the administration of high-flow O2. Patients who are immobile for prolonged periods of time, such as those who are confined to hospital beds or wheelchairs, are prone to a pulmonary embolism. Question number 7. Albuterol, which is a beta-2 agonist, Albuterol, which is a beta-2 agonist, is a generic form for what medication? Ventolin, Brethine, Metoprolol, or Olupent? Albuterol is a generic name for Ventolin. You guys will get, the more experience you get out in the field, the more you'll understand, you'll recognize the names of medications and what the substitutions are, or what the generic views are. Number 8, an acute bacterial infection that results in a swelling of the flap that covers the larynx during swallowing is called what? Croup, laryngitis, epiglottitis, or diphtheria. Remember that little leaf structure? An acute bacterial infection that results in the swelling of the flap that covers the larynx, and that flap is called the epiglottis. That covers the larynx during swallowing is called epiglottitis. That's number C, or letter C. Number 9, a 70-year-old man recently had a heart attack and now complains of severe difficulty breathing, especially when lying flat. He is coughing up pink frothy secretions. The patient is most likely experiencing what? I'll read it again. A 70-year-old man recently had a heart attack and now complains of severe difficulty breathing, especially when he's lying flat. He is coughing up pink frothy sputum. This patient is most likely experiencing what? A, acute right heart failure. B, severe left heart failure. C, an acute onset of bronchitis. Or D, an acute pulmonary embolism. And remember, there's one side of the heart that can't act efficiently, so you get a backup of blood, fluids in the lungs, and that would make the answer B, severe left heart failure. As a result of his recent heart attack, the left side of the patient's heart has been severely damaged. The left side of the heart is responsible for pumping oxygenated blood to the rest of the body. When it fails to do this, blood backs up into the lungs, resulting in pulmonary edema. Signs of pulmonary edema include difficulty breathing, especially when they're lying flat, rapid and shallow respirations, and in severe cases, coughing up pink frothy sputum. Last question, number 10. Which of the following patients is breathing adequately? Which of the following patients is breathing adequately? A, a 36-year-old man with cyanosis around the lips and irregular respirations. B, a 29-year-old woman with respirations of 20 breaths a minute who is conscious and alert. C, a 22-year-old man with labored respirations and a rate of 28 breaths a minute and pale skin. Or D, a 59-year-old woman with difficulty breathing whose respirations are rapid and shallow. A, B, C, or D? And it would be B, a 29-year-old woman with respirations of 20 breaths a minute who is conscious and alert. Because the normal respiration rate for a healthy adult is what? You know what that is, okay? And that is it. So I am all done. You guys take care. That completes the review of Chapter 15. Everybody, please stay safe out there, and we'll talk to you later. Bye-bye.